Hello, friends. I'm Dr. Harvinder Singh. Welcome to our next video podcast. Well, we all know it's July and new psychiatry residents have already started this week. So I decided to post this topic of mental status examination, just going back to our basics. And this will really help our first year residents. So let's begin this topic. In this topic of mental status exam, I will briefly touch on the main factors that we need to discuss and document when we do mental status examination on our patients. And there are 8 points that we need to always ask and look for while doing mental status exam. And these points are appearance, behavior, speech and language, mood and affect, thought process, thought content, cognition, and insight and judgment. In this podcast, I will go over each of them briefly, but please let me know if you do it differently or if there is anything that I'm missing in these topics. So let's begin with the first one, which is appearance of a patient. And appearance section is more of an objective um, observation from the examiner's standpoint. Each topic in mental status examination can help you in terms of the differential diagnosis aspect of patient's treatment planning. So there are many sections in appearance that you need to be mindful of, but I will only talk about important one here. And these are first, age of the patient. By that I mean, does patient appear stated age or older than the stated age? And we know there are many conditions that can make patient look older than their stated age, which includes comorbid substance abuse and even patients with severe depression and patients with treatment resistant schizophrenia with poor self-care can have that. And with poor self-care comes our second point in appearance section, and this is hygiene. You need to document if patient is well dressed or disheveled. And in many mental status exam, they have a different section for odor, but I mostly include plus or minus malodorous with disheveled appearance for patient. And mostly I see this in patients, obviously, who are homeless, but mostly in schizophrenia with dominant negative symptoms, very poor self-care, in severe depression, in dementia patients, older patients with poor self-care, very evident. And you can definitely mention the status of their clothes, their facial hairs, and in some cases, you can look at their nails also and document that in this section of mental status examination. And third point in appearance is the eye contact of the patient. If patient is having good eye contact, poor eye contact, darting eye contact, this should be mentioned. And build of a patient is very relevant, whether a patient is thin, obese, normal build, tall, short, this should be included. And this all goes with what we discussed on top in terms of their stated age and hygiene. And then posture, how the person is with you when you are interviewing them in hospital, whether patient is sitting in their bed, laying in their bed. In your outpatient clinic, are they sitting straight, cross-legged, moving their legs a lot, or anything specific in terms of posture? And also, we talked about eye contact on top. With that, I always include their facial expression, whether a person was smiling, more cautious, suspicious with you, more tense from anxiety, or any relevant factors noted with their facial expression. And after this, I will talk about their level of consciousness, which is very commonly we see mentioned as patient is awake, alert, or it's drowsy or hypervigilant. I have seen mostly in non-psychiatric practice, the mental status examination is patient is awake, alert, oriented to time, place, and person. But mental status examination is more than that. As you can see, this was just the first part of mental status exam, which was appearance section. Now moving to our next section in mental status examination, which is the behavior or psychomotor activity in this section. So let's begin with the behavior aspect. Is patient cooperative with you or not cooperative with you or suspicious like a paranoid patient with schizophrenia? Very important. And this applies to the setting you're seeing patient at. I work on inpatient psychiatry unit, so it also depends on how the patient was admitted to your unit. Patients who have came voluntarily seeking help are mostly cooperative, but patients who are admitted on an involuntary status are very mostly not cooperative with irritable edge, and they mostly terminate the interview early. And patients who are admitted for worsening paranoid delusion with poor insight, poor reality testing are very suspicious in behavior when you talk to them. Mentioning these points play a big role in your differential diagnosis and treatment planning. Now, the next thing in this section is the motor activity. In motor activity, you look at the physical motor activity for a person. Is patient sitting normally with you with no psychomotor activity? Or a person is restless, fidgeting a lot, with evident psychomotor agitation? It's very easily seen in somebody who is having acute manic or mixed episode of bipolar disorder, seen in somebody who has recently used any illicit drugs. There are many, it could be an activating drugs like cocaine, methamphetamine, or a person may be withdrawing from drugs like opioids, benzo, alcohol. It's more of a psychomotor agitation that we see. And you can also see psychomotor retardation, where all the motor activity are reduced significantly, mostly seen in somebody with severe depression and catatonic patients. You need to document that in motor activity aspect. Moving to the third part in this section is the presence or absence of abnormal movements, and this topic is very big topic to cover. There are many examples of abnormal movements: tremors, dystonia, tics. It could be acute extrapyramidal symptoms from antipsychotics. It could be chronic tardive dyskinesia. It could be, so you need to document exactly which part of the body you are seeing these abnormal movements. And I always educate my residents to do AIMS exam whenever you see any abnormal movements, or when you decide to initiate somebody on an antipsychotic medications. For example, acute dystonias are mostly seen around eyes, tongue, neck, shoulder, and trunk areas. Parkinsonian tremors are mostly seen in their hand and wrist, mostly at rest. The pill rolling tremors that we know. Akathisias from antipsychotics are mostly seen in lower extremities with evident restlessness. And the tardive dyskinesia after chronic use of antipsychotics are mostly seen in the lower face and distal extremities. So in that point, the fourth point that you need to mention in this area is the gait. Is patient having normal gait, shuffling gait, or ataxic gait? This can point toward the pathology and differential diagnosis for your patient. So this was our second section in mental status examination of behaviors. So third section is on speech and language. Speech and language is very important area, as many of the neurological disorders can present with speech deficit. As we know, there are many types of aphasias, but in this I will mostly talk about from a psychiatric standpoint. But be mindful of those pathologies that you need to have in your differential diagnosis if there are speech and language issues. But what will you look for in your mental status exam? So first thing is the rate of speech. Is person having normal speech? Is person having rapid or pressured speech, which is more suggestive of mania from bipolar disorder or underlying substance abuse? Or a person is having very slow rate of speech, suggesting likely underlying major depression. And I have also seen mutism or selective mutism in somebody with catatonic presentation also. After that, you'll also look at the flow of the speech. Was speech spontaneous, or was there an evident delay in initiation or evident stuttering after initiation? That should be documented. And then look at the intensity of the speech. Somebody who's agitated, manic, labile will have very loud speech, and somebody on a lower side with major depression will have more of a soft speech. And look at the comprehension aspect of language, and mostly you test for comprehension by giving them 1 followed by 2 followed by 3-step commands, like asking them to point at their body part like ear or eye, or asking them to do 2-step command like touching your eyes and holding a pencil, and then doing a 3-step command. This can test the comprehension aspect of language. And language examination is a very big topic again, but I will only touch the important areas. Comprehension was one. After comprehension is tested, it can tell you regarding the presence of any underlying psychiatric conditions, like somebody with dementia, delirium, or severe depression and anxiety can have some difficulties with comprehensions. Next thing after comprehension is looking at the repetition aspect of their language. If a person is repeating same words or phrases, this can be either in terms of somebody with evident perseveration or echolalia. Well, echolalia is a condition where a patient will be repeating your words exactly, and this can be seen in somebody with schizophrenia or evident bipolar mania sometimes. And if you find any difficulties or abnormalities in any aspect of speech and language, you can definitely go ahead and do more detailed workup. You can even check things like have patient name things, look at their reading and then writing aspect of their language also. But I will not go into detail of that here. So after speech and language, you need to look at mood and affect aspect. So very briefly, we all know mood is what patient is telling you. So this is patient's subjective report of their feelings, emotions. And this can be many things what patient feels. It could be they're feeling angry, they're feeling sad, frustrated, more worried. So you have to use what patient is telling you. whereas affect is your objective report, what you are seeing when you are evaluating a patient. And very briefly, I will say things. So, mental status examination is not a separate thing. You do all these things from the moment patient enters your room and you start the history taking aspect. So these things all begin from the time they are here and the time you finish your evaluation. So you look at the affect during the entire interview, and the first thing you look at is if affect is meeting what patient is telling you in terms of their mood. So one thing you need to always mention is affect congruent or not congruent with the mood. I'm sorry, I noted affect here, but just to make sure mood is congruent or non-congruent with the affect, that's number one. And number two is the range of their affect. If the range is full, which is normal, or if it's more restricted in somebody with major depression, schizophrenia, or if it's more labile with many ranges of affect seen during short 5-minute interview in some cases with bipolar disorder, very evident. They will be happy but very easily getting agitated and then crying next moment and then laughing in next 2 or 3 minutes. Mostly you see that kind of labile affect on inpatient psychiatry unit. And then after these 2 points, you look at the intensity of the affect, which can be normal or flat, which means no emotions are seen, which is more evident of schizophrenia. Constricted is where there are emotions, but they are reduced in intensity, mostly seen in major depression. Or it could be heightened affect, which is consistent with labile range of affect, seen mostly in patients with bipolar disorder. So this was very brief section on mood and affect. After this, you need to monitor for the thought process aspect of mental status examination. Very important part of mental status examination is looking at patients' thought process in terms of how are their thoughts flowing, producing, and if they are organized or not. This can tell us a lot about the underlying pathology, or I should say psychiatric disorder. So here you look at mainly first is the clarity of their thought process. If it is coherent or incoherent, like in somebody with psychotic disorders, where a person is losing touch with reality frequently. And same way, is it logical or illogical? And second part in thought process is looking at the flow of their thoughts or association of their thoughts. And normal here is the goal-directed thought process. And the other things that we see is circumstantial thought process, where a person will begin a topic but then goes to the side and start talking about something else, and it will take some time for a person to come back. Most of the time a redirection is needed when you talk and question people. That's more of a circumstantial thought process. And the extreme form is tangential thought process, where a person get distracted easily and start talking about other topics and never come back to the topic that they begin with. Mostly we see this in a bipolar disorder, manic or mixed phases, but also evident in delirious condition and even in somebody with actively substance-induced mood or psychotic disorder. The other things that we see in somebody with manic or substance-induced disorders are flight of ideas, going on to loose associations, going on to word salad where nothing is understandable. So these are like the severity of the disorganized active thought process. And last but not least is thought blocking, evident in somebody who is actively responding to internal stimuli, will have evident pauses, and mostly seen in somebody with schizophrenia. So this will tell you a lot about what areas of diagnosis you need to focus on. But be mindful, on an inpatient psych unit, you will see patients where they will have most of them, and it is very difficult to pinpoint exact diagnosis. So I always say, when you see these kind of thought processes having both mood and psychotic symptoms, have both of the diagnosis, mood disorder diagnosis and psychotic disorder diagnosis, in a rule out, rather than focusing on making the exact diagnosis on day one. So moving forward from thought process, next is thought content. What does these thought contain? And I think we all know how important this area is. Especially, actually, it applies to all the setting, but I work on inpatient psych unit, so very important area when a person is presenting with severity of their underlying mood or psychotic symptoms. So here we'll just briefly touch each thought content that you need to assess and document here. First, in a psychotic symptom class is hallucinations. Not only focusing on auditory and visual, but also assess for olfactory and somatic hallucinations. Here in auditory hallucination, very important to go into details of those, whether they are command or non-command in nature, whether it's one or more than one voices, is it male or female, does it remind them of somebody that they know, which could point more toward PTSD also in some cases. And I always ask if the voices are coming from inside their head or outside their head. Same goes for visual hallucination details. Is it only a dark shadow or a full formed human figure? And other areas of that. And second thing after hallucination is the delusion aspect, persecutory delusion, more paranoia there, grandiose delusions, very evident in bipolar disorder with most recent episode manic, and somatic delusions are common. Mostly I see them in stimulant or cocaine induced mood or psychotic disorders. And one of the example is delusional parasitosis. And then in bipolar mania you see erotomania, and in schizophrenia you can see idea of reference, where people feel everyone is talking or focused on them. But very important thought content disorders to monitor for and look for. And in these cases, collaborating with family or close friend is highly important here. And then after these two psychotic disorder symptoms, you need to also look for obsessions, very commonly seen in anxiety disorder, depression, underlying OCD. And also I also look for the way a person is dealing with their obsession. What I mean is there associated compulsive behavior to relieve the stress or distress associated with intrusive obsessive thinking. And then most important is present or absence of suicidal ideation. Actually, the assessment of suicidal ideation is a chapter in itself, but I will briefly talk about some points that you should never miss, which is present or absence of plans with suicidal ideations. And here I will go into more details of suicidal ideations with patient just to monitor and assess them for risk factors, which is duration of suicidal ideations and what made them not act on these suicidal ideations, to look for protective factors. Past history of suicidal attempt or ideation is important, and most important risk factor for future occurrence of suicidal attempts or ideations. And this, after this, need to look for homicidal ideation, specific person that they are focused on. If so, you have the duty to warn by either involving the police or informing this person. And I always also mention access to gun, firearms, or any mean of harm that person can use after leaving your clinic or discharge from inpatient psychiatry unit. Now, this was the thought content aspect of mental status examination. Moving to the seventh and I think most important part that many of us sometimes miss is the cognition aspect. Well, this is a very, very big topic, and I will try to summarize them in few sections here. But please let me know if you want me to go into details of this. I can post a next video podcast on details of each of this. But what do you look for in the cognition aspect of mental status examination? First is the orientation aspect. Is person oriented to time, place, and person? And this actually more goes with the delirium evaluation, and also in older patients with dementia with behavioral disturbance. Very important to look for time, place, and person. And in the mini mental status examination, they go little further, and they also look for season, year, date, day, and month. And they also ask you which state you're in, which country you're in, town, hospital or clinic, or floor of the clinic or hospital that you're in. So this is the orientation aspect. Then you look at the attention aspect. We all know that attention is a person's ability to focus, and there are many tests that you can do to check for the attention status of a patient. Here you can ask the patient to repeat digits. You can start with giving them 1 digits, then 2 digits, and then 3 digits. What I mean is you can give them 1-digit numbers like, can you repeat 4821? And if they are able to do that, you can go to a 2-digit repetition like 22, 37, 84, and then move on to 3 digits. Attention is a very short thing. You just need to see if they're able to focus immediately. And after attention, you look at the next aspect of attention, which is concentration. So concentration is next step to attention. We know attention is person's ability to focus. Concentration is person's ability to sustain that attention that we just tested. And again, there are many ways to test concentration. Here I will be using our most commonly used test called Mini Mental Status Examination, or MOCA. But be mindful, I think MOCA is more copyrighted now. You need to do some testing and get credentialed in using MOCA now. But what we use to test concentration is these tests. You can give them serial sevens, ask them to start subtracting from 100 minus 7, and keep subtracting 7 from that. In older patients, more than 65 years of age, or depending on their education background, if they have difficulty with that, I mostly start with 20 and do serial 3s, keep subtracting 3 from that. And you can also ask them to repeat the months of the year backward, or you can give them a word and ask them to spell it backwards. After checking for attention and concentration, you need to monitor for the aspect of the memory. And we know there are many types of memory, but mainly there are short-term memory and long-term memory. And long-term memory have also 2 aspects or 2 types of long-term memory. But we will not go into details of that. Again, memory is a big topic to test in people who are struggling with that. But in mental status examination for short-term memory, you can give them 3 words and they can recall after 5 minutes. That will tell you more of a short-term memory aspect. Mini mental status and MOCA have these features that you can use. For long-term memory, the first type of long-term memory is called the episodic memory, which is more of a personalized memory. Here you can ask a person to remember important events in their life, and very important to confirm these things with their family members because of the risk of confabulation, which can happen in somebody with comorbid alcohol abuse history or in a patient with evident grandiose delusions and other aspects. So, this is episodic memory, just looking at important events in patient's life, which can mean the marriage, birth of the child, the important job that they started or retired, retirement date, those kind of thing. And after episodic memory is the semantic memory. Well, we all know that semantic memory is more about the important journal information. Here you can ask them about our last few presidents, country capitals, and other important things or important events that happened in last 10 years that a person should be aware of. And the next thing in cognition after memory testing is the abstraction check evaluation. Here you have to see if there is an abstract or concrete thinking. And mostly what I do is I always check this on my first question when I start the evaluation, which is what brought you to the hospital or to the clinic. Somebody with concrete thinking will say, ambulance brought me here, or a family member brought me here, rather than telling me the symptoms presentation, like my depression was getting worse. So this can tell you a lot about their abstraction aspect of cognition. So abstract thinking is very important aspect of the frontal and prefrontal cortex that we know of. So abstract thinking is your ability or capacity to have meanings of the word beyond their literal meanings. And it's very important for patients to analyze information. You can actually go into details of more testing if you find there is more of a concrete thinking going on. And last thing in cognition is the constructional and visual spatial ability testing. And I always ask my patients when I see many of the cognitive areas are affected, clock drawing is very important thing. You can just give them a plain paper, ask them to draw a clock, and you can ask them to number all the numbers in clock and make a clock showing 10 past 10. And the next thing I do is two cube drawing one over each other. Mocha has that picture. But clock drawing is very important in these cases. It can tell you a lot about the both hemisphere and other aspect of various neurological pathologies. So this was our seventh section on cognition. The last section in mental status examination is their insight and judgment. This is all very self-explanatory. You don't have to go into details, but you will monitor for insight and judgment during your entire evaluation. So starting with insight. What is insight? Insight is a patient's understanding of not only their symptoms, but also the reason for admission or presentation to your clinic, the diagnosis that you are talking about. And also I look at how much person understand the impact of these symptoms, not only on them, but in their daily functioning, which is for people around them, which is their significant other, parents, or other family members, on their current job, or if there are any legal aspect because of that. Very important in my practice. I see this in a person who is struggling with bipolar disorder, with mania. They're spending a lot and buying a lot things or going into bankruptcy. Their significant others are very concerned, but patient is not in most cases. In someone with increased in comorbid substance abuse, getting in legal troubles, DUI, lost their license but have no insight into seriousness of that, and person with increased depression or with very easy frustration or bipolar impulsivity, getting into fight at job, or losing jobs frequently and not able to sustain their job for long duration, not having insight into how their symptoms are contributing to these. So that's what insight is. And judgment is the next step after insight. So, judgment is patient's decision or action regarding their underlying, not only their underlying psychiatric condition, but also in their recent day to day activities. And the way to test judgment, I mean, you all know, very common question that we ask in residency and even after is, if you find a stamped addressed letter on the street, what will you do? Very, very basic question, but can tell you a lot about the judgment aspect from a patient standpoint. And very important thing that I have noticed is if insight is impaired, as a result, judgment is more likely to be impaired. Like we just talked about, somebody with increase in drug use, alcohol use, or untreated bipolar mania will have impaired insight, thereby making impaired judgment on that. So very important point in mental status examination, and this is the last point in mental status examination. So I will just summarize everything here. So when you do a mental status examination, very, very important to look for and document all these 8 sections. And I will try to, and please let me know if you'd want me to talk into details of any of these sections or topic. I'm trying my best not to make very, very long videos. But thank you, friends, again. Thanks for watching this video podcast. And if you have not already done, do like us on Facebook, follow us on Twitter, subscribe to this YouTube channel, and like us on our LinkedIn page also. If you have any questions, do not hesitate. This is my email address. Contact me directly. And last but not least, if you have not done already, do subscribe to our guide or a course called Physician's Guide for Clinical Psychiatry. I will place this link below. So thank you again. You all have a good day. Take care. Bye.